Good evening. Welcome, and I want to thank you all for attending the first of our revamped Dalla Lana Leadership Lectures. Tonight we're fortunate to do this in partnership with the Faculty of Medicine and with the Vice President of Research and Innovation. And I'm happy to personally welcome you. I'm Staney Brown. I'm the Interim Dean of the school, and I'm excited to see such a full crowd here tonight. But before we start, I want to make sure that we acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and more recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we're grateful to be able to have the opportunity to work on this land. Now, a little bit of housekeeping. For those of you who are tweeting, the hashtags are U of T Innovates and support the report. For those of you who are my age or older, don't worry about it. And I should let folks know that the lecture is going to be videotaped and it's going to be available a little while later on our website. So look, this is an important step for us because it's the first of our revamped series, but it's also something that builds on a history of innovation at the University of Toronto. And with this in mind, we're really pleased to be presenting an all-female panel of health innovators to spark discussion tonight, like all of our leadership series are supposed to do, about important issues facing our health system and health more generally in this country. Now, it's also an important time to do this because 2017 marks several important anniversaries for the school and for the university. It's the 100th anniversary of the Connaught Laboratories. It's the 90th anniversary of the School of Public Health, and it's the 70th anniversary of the Institute of Health Policy Management and Evaluation. And key to all of this is Gerald FitzGerald, or Gerry FitzGerald. He's the founder of the Connaught Antitoxin Laboratories and the University Farm, and he was also the person who helped establish the School of Hygiene 10 years later that became the School of Public Health. Now, his vision for the labs and the school were threefold: the preparation of low-cost, high-quality preventive medicines for free national distribution through government departments of health. As well, a research arm to develop new products to meet the constant threat of infectious disease, and education that would pass on the torch of knowledge to future generations of public health workers. And his idea to manufacture vaccines and antitoxins at the University of Toronto and then distribute them free to all Canadians as a public service was an elegant innovation when it came along in 1917. But it was also something that helped give birth to the idea that we could provide health care free for all. It was the first commercial drug firm operated by an academic institution, and it helped establish Canada as #1 in preventive health and medicine, something that's been picked up by the Lalonde Report, the Ottawa Declaration, and any number of other efforts to put health first. In fact, by 1940, Hamilton and Toronto were the first two cities in the world that were officially diphtheria-free. So, 7 years after his death, the university established the Department of Hospital Administration, which was the first hospital administration program in English-speaking Canada, and another place where innovation continued. One of the chief figures on that is actually Peggy Leah, who modernized not only in Canada, but across North America, the way that we do health administration and health management education. In addition to a singular and similar track record of public service, which included completing the Health Services Restructuring Commission and finishing the reports for that commission that still stand as a model for reform today. So, as you think about all the contributions of innovators at the University of Toronto, please take a second, read more about the history of the labs and the school. Professor Christopher Ruddy, who's a historian and a professor with us, has prepared the banners out in the hallway. And I hope it gives you an opportunity to remember and celebrate the proud history of health innovation here at the university. But keep in mind a couple other things as well during tonight's presentation, because they're themes that were important in 1917, in 1927, in 1947, and are still important today in 2017. First, the talks today help reinforce the context and the understanding about the ideas and ideals that shape and drive health innovation today. How we continue to work together here at the university to narrow the gap between research and impact, while sticking true to the values of making sure that those innovations are accessible to everyone. Second, this is part of a long history that we know will continue. The Connaught Laboratories is a signal and an important start in the link between government, local industry, and the university, and one that continues today. And today we regularly collaborate with the provincial government and its agencies, and any decision makers with whom we can convince to take a few minutes with us to give more meaning to our work, to make sure that we get outside of the ivory tower, and when we do have evidence, to make sure it gets into the hands in a way that's useful to the people who make decisions and guide the system. And finally, all of this evidence not only creates discoveries, not only helps guide decisions, but it also helps build a healthy economy. Vivek will talk about this more in a few seconds, but Connaught Laboratories gives birth to a major Canadian industry. Now, it's my time to get off the stage, and it's my pleasure to introduce Professor Vivica Whelmed. He's the Vice President of Research and Innovation, but, and you can make the decision after tonight's event, he's also the person who hired me into the university, for which I'm grateful, and hopefully he is too. He's my former chair in Health Policy Management Evaluation. He's the founding president of Public Health Ontario. He's held a number of roles across this university, across the province, and nationally and internationally. He's worked in the private and in the public sectors. And right now he's continuing this not only as the VPRI here, but also as the chair of the Toronto Central Local Health Integration Networks Board. Please welcome Vivek.
Thanks, Steny, for that kind introduction, and I don't think I made a mistake when we hired you. So it's my pleasure to say a few words about the main celebration tonight, which is the 100th anniversary of the Connaught Labs, and then to introduce our panel, which is really going to be about looking forward. So a few minutes of history, and then we're going to be into looking forward. So I'll start with the story of John FitzGerald, and Steny mentioned his significant roles. This is a story that goes back over 100 years ago. John FitzGerald was doing house calls, which doctors used to do in those days. It was an unfortunate time. There was a major diphtheria outbreak on, and there weren't a lot of treatments available. Diphtheria antitoxin was available as preventative, but it was in very limited supply. It was at that time manufactured in New York in the public health labs, and then distributed across the United States and Canada from there. And Dr. FitzGerald was doing a house call. He was with a family that had 2 children, but they could only afford the antitoxin of 1 dose. And they asked, the parents asked him to step into another room while they chose which of their children would get the diphtheria antitoxin. And that moment had a significant effect on him. And he said, no one should have to face that kind of choice, but which of their children can get a particular drug, treatment, antitoxin. And so he decided that he was going to find a way to start to manufacture diphtheria antitoxin here in Toronto and make it available at low cost. And that's where the phrase "putting health within reach of everyone" came to be. And one of the many great histories of the Connaught Labs has that title, "Within Reach of Everyone." So he went to a barn on Barton Street. So think of inventors in their garage that we talk about. In 1913, 1914, when this was starting, barns were the garage because you needed horses and the horse serum to extract the antitoxin. And starting with that lab, he created the Antitoxin Lab here at the University of Toronto. You have to remember that Dr. FitzGerald at the time was an assistant professor. There wasn't any department that he was really part of. Faculty of Medicine didn't actually do a lot of research at the time. And he was trying to do these things in an environment where there wasn't a lot of support. Somehow he managed to get the attention of the university president and said, we got to figure out a way to scale up this production. And there was a member of the Board of Governors, Colonel Interim, who saw some very important value to what Dr. FitzGerald was proposing, because as you can imagine, that this was World War I was well underway, and the production of biologics, tetanus, there was a number of other areas where they saw the need for the armed forces. And so Colonel Interim bought a farm up in Downsview and also donated the funds to the university to build the first facility up there. And at that point, the province of Ontario also stepped in and provided another match towards his donation. So it's the second very important point I want to make, is that we rely on private philanthropy and public funds coming from our governments to do the great work that we do. And that was true back in 1917 and continues to be true today. What's changed is the amount of the province's donation at the time was $75,000, which matched the value of those lands and the building that Colonel Interim built there to build what came to be known as the Connaught Farm and Laboratories. And just the name was for the Duke of Connaught, who's also Prince Albert, and had been the Governor General of Canada up until 1916. So that's where the name came from. So during the time that Dr. FitzGerald was doing all of this work, we didn't have tech transfer offices. Nobody, I don't think we had lawyers working at the university on intellectual property rights, and nobody was worried about what tax incentives or anything else. They just went out and did it. And I think that's another important lesson about innovation, is that you just go out and you get things done. But Adalsteinn noted that in building this, it wasn't just about the production of the antitoxin or the vaccines, insulin, and other things that they went on to do. Dr. FitzGerald also saw the importance of having a research enterprise embedded within the Connaught Labs, and then the Connaught Labs very tightly associated with an academic enterprise, the School of Hygiene, and having all of these entities working in close proximity. And so you had the movement of researchers and staff between the education, between the research, and between the commercial arms. And again, as we look to what we're doing in our university community now, look at what happens in Mars Discovery District, we're recreating those kinds of environments in today's world. So in the interest of getting on with the panel, I won't go through the bulk of the history of the Connaught Labs. We're going to have other moments to celebrate some of the great achievements, such as the production of insulin, the growth of the company in the slideshow and on the banners. There's a lot of the great stories that have come out. But I'll just close this part by saying what the Connaught Labs have left as a legacy for the University of Toronto. So when we got to the 1960s, we got to the point where the Connaught Labs were growing into essentially a global multinational. And they were manufacturing vaccines and other drugs and distributing them around the world. And universities then and universities now are not great organizations to try to run global companies out of. And so at the time, the University Board of Governors sold the Connaught Laboratories to the Canada Development Corporation, and then through a series of transactions, what we realized was Sanofi Pasteur, which continues to operate on those original lands up in Downsview. And Mark Luvinen is here with us today, and I know there's some other colleagues from Sanofi Pasteur. He retired as the president of Sanofi. He passed a year ago, but he was just reminding me that he actually started working when it was still the Connaught Laboratories, and so he's a connection to that history. What the university got out of that was the proceeds of the sale, which were invested in what we refer to now as the Connaught Fund, and it continues to this day and is worth over $100 million, generates $4 million a year that we're able to invest back in to our research enterprise. And we have four main areas of investment. We support Connaught International Doctoral Scholarships to continue to try to recruit the very best graduate students in the world to come and study here at the University of Toronto. Support for new faculty, and that's where we see a significant need to help faculty get their start in the research enterprise. Support for innovation activities, because we need to continue to invest in those types of activities. And when we get university proceeds from major commercialization events, those go back into the Connaught Fund. And then finally, we invest in grand challenges, really big interdisciplinary projects. And we just announced earlier this week the latest round of those. Prabhat from the Dalla School is leading one of the teams for the Global Challenge program. And so that's the legacy for the University of Toronto. And I want to emphasize that that is really important because research is a long game. We often get excited about research findings. We get excited about the events that lead to new policies, programs, commercialization of drugs or treatments. But we know that those results come from many years, decades of fundamental work that people do. And one of the other main themes of tonight is around investing in fundamental research, and the report hashtag is really around that. President Emeritus David Naylor chaired a panel on fundamental science, which showed that public funding for investigator-led research has decreased by about a third in the last decade. And we need to make significant reinvestments in research. On your chairs as you came in were little postcards, and tonight's our launch event for postcard writing campaign to our Minister of Science. We've also provided a U of T entrepreneurship pen so you can fill out your postcards, and the Dean will tell you at the end what you can do with the postcards at the end of the evening. But the main message is that we need that kind of support for fundamental research, because it's that support that makes it possible for us to continue to do the research that will lead to the innovations that will help benefit society. So we have three researchers on today's panel. We did not set out to not have a manel. If any of you that read the Globe and Mail earlier this week, there was an op-ed on the dangers of manels, all male panels. Steny and I were brainstorming a little while back, and we thought we'd want to get someone working sort of in the basic science area, someone working in health services and maybe with digital technologies, and someone working on the population health side with innovations. And we were brainstorming, and we came up with the three names, and actually all three people we thought of agreed to be on this panel, and they just happened to all be women. But I think it's a great signal of the breadth of talent that we have here at the university. I was at last week, there's a few people in the audience, I think were there as well, at the Gender Summit in Montreal, where a lot of time was spent talking about how we promote women in science and in all areas of society. And I think we're doing a great job of that here at the University of Toronto, and we'll see more in our panel in a few minutes. And all of our researchers that are going to be speaking tonight have great students working with them, and I know many of their students are here in attendance. If you could just stand up all of the students of our 3 panelists. They're here. That's great. So a round of applause for our students. And I know there are many other students, because one of the things, again, in our advocacy for research is it's not just about the research itself. That's obviously important and what the research is going to lead to, but it's the training environments that our research environment that creates that is leading to the next generation of researchers, and people will work in all areas of society, in companies like Sanofi Pasteur, in government, in hospitals, in all areas of society to carry that knowledge out and that expertise. So I'll briefly introduce our 3 panelists and then invite them up. They'll each speak for about 10 minutes, and then we'll have time for a discussion. So our first speaker will be Leah Cohen, who's a professor of molecular genetics in the Faculty of Medicine and the Kanata Research Chair in Microbial Genomics and Infectious Disease. Her lab focuses on diverse facets of biology and the evolution of fungal pathogens. And it's not something that we think about a lot, but fungi have staggering impact on global health. Her basic research has the potential to lead to novel therapeutic strategies for this disease. Our second panelist will be Emily Cito, who's an assistant professor of health informatics in the Institute of Health Policy Management and Evaluation in the Dalla School of Public Health. Professor Cito is also an engineer, and she focuses on how mobile medical technologies might facilitate patient self-care and clinical decision support for chronic and complex disease management. So her work is really looking at bridging the gap between understanding chronic disease management and then operationalizing how we can use new technologies to improve patients' lives. And our third speaker will be Laura Rosella, assistant professor in epidemiology at the Dalla School of Public Health and the Kanata Research Chair in Population Health Analytics. And she's developed a population health analytics lab that focuses on projecting the incidence and occurrence of chronic disease and helping us in modeling prevention strategies for chronic diseases. She works with multiple data sources, links across multiple sources of information to create these tools, and she works very closely in collaboration with decision makers in public health, in local health integration networks, and the broader health system. She's also worked closely with Public Health Ontario on that interface. So with that, I'll invite Leah to come up and make her remarks, and then each of the 3 panelists will come up.
Thanks so much, Vivek. So I'd like to begin by first thanking the organizers for organizing this fantastic event. It's really a pleasure to be part of this event, celebrating the importance and impact of innovation at the University of Toronto. And I really appreciate the invitation to have the opportunity to speak about the importance of fundamental science in terms of addressing the greatest challenges facing the world today. So I will talk a bit about my research, but I'm going to frame this in a sort of a bigger picture of why we do what we do and the impact this will have and the importance of basic science. And I'm absolutely thrilled that we started by acknowledging the students, because they really are the heart and soul of what we're doing here, and we're really here in part to drive our research and innovation agenda and in part to train the next generation of scientists. So that's absolutely front and center. So to put this in perspective, I think we're at a crisis point on a number of fronts, and you can see this exquisitely clear with the many thousands of scientists recently issuing a global warning about climate change, and also with the World Health Organization now ranking antimicrobial resistance as one of the greatest threats to human health today. And I'm going to focus my talk today, as aligned with my research area, which focuses on antimicrobial resistance, so this latter threat to global health. So it's exquisitely clear that antimicrobial agents completely revolutionized modern medicine, and they made previously uncurable illnesses like pneumonia, tuberculosis, polio, diphtheria, as you've heard of, treatable. The origins of antibiotics are actually a fantastic discovery that fundamentally trace back to basic science, so I'll just highlight that briefly here. This was a legendary discovery of Alexander Fleming back in 1928, so we'll look back once more briefly before we look forward. So this was a great discovery where Alexander Fleming was interested in studying this particular bacterium that preyed on individuals with weakened immune systems. So that he was studying this bacterium, had a petri dish, a little plate to feed the bacteria, and he forgot about it on his research bench, went away on vacation, and came back 2 weeks later. And in the interval while he was away, a random spore from a fungus, a filamentous fungus, floated by, dropped onto the plate, and made a home. And what it did was secrete a mysterious substance that killed off the bacteria. So when he came back, he discovered this substance, and he tracked it down and figured out that this was an antibiotic. This was a molecule that could kill bacteria called penicillin. The fungus that produced it was Penicillium. And this medicine that came from this really basic science discovery, fundamentally investigating a bacteria and an interaction between a bacteria and a rogue fungus that came on the scene, led to penicillin, which saved over 200 million lives and continues to save millions of lives today. And I will note that the connection with the Connaught Labs remains in this context as well, as the Connaught Labs led the charge with the production of penicillin, which was key in time of D-Day during World War II. So you've heard about how the Connaught Labs were pioneers in terms of the development of many medicines, vaccines, serums that became the front line of defense for treating many infectious diseases. And all of these crucial inventions and interventions really owe their origins to basic science, and you've heard that beautifully from Vivek's talk. So what I want to highlight here is that we're now at a moment where we have to imagine a world without effective treatments for infectious disease. That's where we're headed, and it's becoming exquisitely clear that the evolution of drug resistance dramatically outpaces the rate at which new drugs are being developed. So our global interconnectivity with airline travel and beyond makes it such that resistant strains can emerge anywhere in the world and rapidly disseminate with a global context. It's clear that resistant microbes are now killing about 500,000 people per year. Resistance threatens our ability to cure very common infectious diseases, and it also threatens to undermine major medical advances, such as our capacity to do surgery, to do transplants, and to treat cancer, for example. It's expected that by 2050, about 10 million people will die globally each year due to infectious diseases that were previously curable, as these old diseases return full force. It's clear that these previous sort of infectious diseases that we used to be able to cure are expected to overtake cancer and diabetes in terms of their impact on human health. And this is further exacerbated by the emergence of new infections, such as Ebola and Zika, to just name a few. So with this urgent need for new antimicrobials, it's clear that fundamental academic scientists take the lead on discovering new antimicrobial targets and developing new medicines. So economic models have not been particularly favorable for development of anti-infectives in profit-driven pharmaceutical companies. There's many reasons for this. In part, it's because treatments with anti-infectives are typically of short duration, right, compared to treatments for diabetes, for example, or cholesterol, which is much more long-term. And also, with the rapid evolution of drug resistance, new drugs are often rendered obsolete. So it's a very different and difficult business model. So it's becoming clear that it's going to fall to academic scientists to chart the future course and to populate the pipelines for future drug discovery. And it's really for these reasons that my research focuses on developing new therapeutics for drug-resistant microbes. We have tackled this by using fundamental biology to understand the mechanisms by which microbes evolve drug resistance and the mechanisms by which they cause disease. By uncovering these fundamental mechanisms, we're able to identify new targets for therapeutic intervention. So in other words, we identify key regulators that enable drug resistance and disease, and then if we can identify molecules that engage with those regulators and inhibit them, that provides new material for drug development. And our work, as Vivek mentioned, focused on a group of organisms that most people don't think about very often. So these are fungal pathogens. So these now kill approximately 1.5 million people every year, on par with malaria and tuberculosis, and yet most people don't think of these when they think of life-threatening infectious disease. And it's notable that fungi are quite different from bacteria and viruses because they are actually much more closely related to their human host. This has made fungi incredible model systems to understand human biology, but it also means it's incredibly difficult to kill fungal pathogens with drugs that don't also cause very serious toxicity to the human host. So these fungal pathogens are not only directly killing people, but they're also the largest threat to agricultural crops, and they're also causing rapid extinction of our frogs and bat species, so a major threat to biodiversity. So speaking about our research with no slides to a broad audience is a little challenging, so we're going to keep it at a high level. And I'm going to tell you that we tackle this using state-of-the-art but very fundamental approaches. And we've done this using many different partnerships. We've partnered with academics, we've partnered with industry, and we've partnered with these different organizations to create amazing genetic resources. So mutant libraries that allow us to investigate the function of every single gene in a pathogen genome so that we can ask which genes are required for the organism to evolve drug resistance, which genes are required for the organism to cause disease. And as a complementary approach, we can also again collaborate with industry and also with academic groups and screen large libraries of small molecules. These would include natural products like those made by penicillium and also synthetic molecules that have been developed in industry. We can screen these molecules and look for which ones might have potential to cure infections. And by these complementary approaches, we've developed many new exciting programs for preclinical drug development. And I'll just highlight one conceptual example, which was a real sort of change in paradigm about how we think about drug discovery for antifungals. So one of our most exciting discoveries was uncovering an Achilles heel of fungal pathogens. So this is sort of the weak point in a fungal pathogen, where if we inhibit this Achilles heel, we essentially break the fungal system that's required to respond to stress. And these stresses can include stresses encountered in the human host, or stresses that are induced upon treatment exposure to antifungal drugs. So we discovered an Achilles heel, which is a chaperone protein called the HSP90, and this protein stabilizes hundreds of other proteins in the cell. It's kind of the hub of the control point of cellular circuitry. So we've developed molecules that can inhibit this protein, and by doing so, they can completely abolish drug resistance in all of the fungal pathogens and enhance the activity of all of the antifungal drugs in multiple model systems. So we think that this is a really powerful strategy and now opens the door to combination therapy for treating fungal infections. So I want to highlight that this work has all been achieved through fundamental science funding. We've been funded for over 10 years from the Connaught New Investigator Fund as a start, CIHR, NSERC, Grand Challenges Canada, Canada Research Chairs, Burroughs Wellcome Fund, NIH, and many others. And this funding has been absolutely crucial to achieve groundbreaking discoveries and build a pipeline that allows us to take these discoveries from our academic bench all the way through to the patient bedside. I will highlight without public funding, we would never have discovered these fundamental mechanisms of drug resistance and disease, and we really think these hold the key to future development of new antimicrobials. And I will also highlight most recently, we've actually now founded a new company. This company is called Bright Angel Therapeutics. And the role of this company will be to help take these fundamental discoveries from our academic labs, led by our students, and to transition these into the hands of medicinal chemists and others to take this all the way through to developing new therapeutics. I will also highlight that our new company is enabled by an amazing partnership with another company called Schrödinger, who are really a powerhouse in silico drug discovery and design. And so it is through these partnerships, also with Mars Innovation, that we're able to really do the full course of research from fundamental discovery all the way through to developing medicines to treat patients. So I want to highlight also in the last few moments that as chair of molecular genetics, I have the privilege to work with an amazing complement of outstanding world-class faculty and students. And it's important to highlight that the breadth of research is simply remarkable. So we've been transforming how we understand the genetic basis of human disease and creating new opportunities not only to deal and thwart infectious disease, but to regenerate tissues and also to treat really diverse diseases such as cancer, diabetes, Parkinson's, Alzheimer's, and cardiovascular disease. And I want to highlight that the engine of scientific excellence has really sparked outstanding collaborations across hospitals, across universities, between countries, with industry, and many, many initiatives to commercialize foundational discoveries, providing really rigorous training also for the next generation of scientists, some of whom are in this audience. So I think there's really a historic opportunity right now to raise the bar for biomedical research in Canada and to accelerate the impact to health and quality of life worldwide. To do so really requires the vision to invest in fundamental science and to enable the innovation, partnership, and training that are really required to solve the world's greatest challenges today and tomorrow. Thanks.
Thank you. I'm really honored to be here participating in today's celebration and to have the opportunity to share some thoughts around how technology and innovation are crossing over from research to having real impact on patients' lives. This is a really exciting time that we're living in because we're at a turning point in the way that health is being managed. We have the traditional and essential line of drug treatments that Dr. Cohen just spoke about, but we also now have technologies such as health apps, wearables, and other innovations that connect to the Internet of Things that are really starting to play an important role in health management. I think a good example of this is in terms of diabetes management. We're here partly to celebrate the 100th anniversary of the Connaught Labs, where insulin was being manufactured. The combination of this life-saving drug, as well as newer and emerging technologies such as home glucometers, diabetes apps, as well as now the artificial pancreas, is allowing us to have a much more effective multi-pronged approach to diabetes management. In particular, there's been a lot of buzz around the idea around doctors being able to prescribe apps, the same as they prescribe medicine. In some instances, it's actually been shown that some of these apps can have an impact on health outcomes as large and significant as those of medication. This can be a very powerful tool because of the accessibility of the medium, from low and middle income countries to high income countries to remote to urban regions, as well as across the spectrum of socio-technical status. The vast majority of people are now connected somehow through mobile technologies. This provides an unprecedented opportunity for us to connect patients, no matter where they live, to the right providers and interventions at the right time. It also affords the opportunity to us to support the new generation of consumers and patients who not only want to be engaged, but are demanding that they are active participants in their own healthcare. However, because of the speed of this technology advancing, and also because it's driven by the consumer, it's a little bit like the Wild West out there in this area. We have now over 325,000 health apps that people can download, and most of them are not really used and are of dubious value. Added to this, there's this lag in policy development, again, because of the speed of technology advancing. And unlike drugs, we have to consider these technologies in the context of socio-technical systems, which make implementation of them quite complex. Basically, patients and their healthcare providers just don't know what to use because they don't know what works for them. As researchers, I think we play an important role in 3 different areas. First, I think researchers are developing quality innovations. And this is supported by this movement towards user-centered design and participatory design. So gone are the days where innovators are really in the garages, as Dr. Goel was saying. But now what we're doing is bringing in the clinicians and the patients throughout the development cycle. And this is providing much more usable and useful technologies. Secondly, researchers are providing the evidence to determine the efficacy of our innovations. I think we're coming to the realization that we need newer and more appropriate ways to provide evidence because of the incredibly fast rate technology is advancing. It's known that it takes on average 17 years for evidence from a randomized control trial to get into practice. So to put things into perspective, it would be about now in 2017 that we'd be trying to put into practice evidence around the use of Palm Pilots into our healthcare system. And I'm probably dating myself because many of you maybe not know what Palm Pilots are. The third area researchers are making huge strides in is what I consider maybe the most important and the most difficult thing to really achieve, and that is finding how to implement these new innovations. Without understanding how to implement these innovations, we really have no chance of sustaining, yet alone scaling our innovations. But figuring this out is not a trivial task. As you know, our healthcare system is quite complex, and each of our healthcare settings has its own unique set of barriers and facilitators to adoption. Fortunately, we do have many strong implementation science researchers at U of T, and they're doing amazing work and moving the needle on this front. As you probably would have guessed, the space that I get to play in is around mobile health, also known as mHealth, and I've been doing so for about 10 years now. Along the way, we've had some really hard lessons learned, and as researchers, we don't like to use the F word very much in terms of their research trials, and by that I mean the word failure. But we have had our share of trials that just didn't go the way that we hoped it would. And personally, I think that these trials have provided knowledge that is just as important as successes if we really are to bridge that gap between research and impact. However, not all our experiences have been negative. We have had some notable successes along the way. As an example, we now have a sustained smartphone-based telemonitoring system that's being used at the heart failure clinic at the University Health Network. And this technology was built in-house, and the program has been in operation for over a year now. So basically, we're able to monitor patients wherever they live. And they would take daily measurements, and we use this data and put them into algorithms to provide them with real-time and tailored self-care messages, and we can alert their clinicians at the earliest signs that their patients are having worsening health. We're also going to be starting some new programs in chronic kidney disease, and other deployments are on the horizon. I believe we can contribute any of our successes largely to two very fundamental factors. The first is the partnerships that we've developed over the years. We've been very fortunate to be able to work with a team, and more accurately, an army of different stakeholders, including our healthcare professionals who act as our clinical champions. We have worked with a number of healthcare institutions, as well as decision makers in government, industry, and of course the patients who are volunteering their time and their feedback. I also want to give a shout out to the students who have been working so hard on our projects, and again, without them, I don't think we would have been successful. The second factor is around research funding. Obviously, without that, we wouldn't be able to do our research. And we have been able to leverage some public funding through the Tri-Council as well as the Ministry of Health and Long-Term Care. We've also been able to benefit from philanthropic funding, such as through the Ted Rogers Foundation. Finally, and relevant to today's celebration, I was fortunate enough to receive the Connaught New Investigator Award, and I have been awarded some funding through that, which I have used to do some research around implementation of our technologies in different care models. So just to conclude, we are living in a very different world than even a decade ago. And I think that with the emergence of new technologies, it'll be really interesting to see what happens in the next 10 years and how we're able to harness this opportunity to really change the way that healthcare is being managed. Thank you.
Thank you very much for this opportunity. It's a real honor to follow such esteemed female scientists. At the heart of any important innovation is a deep motivation. And for us, that motivation is the desire for better health for all. And as a population health researcher, I look at innovation in a slightly different but complementary way that you've heard from my colleagues today. I look at health at the macro or the population level, and sometimes patterns are only apparent when you study health thousands and millions of people at a time. But I think studying population health and innovation is important for a few reasons. First, studying the population health impact of innovation tells us if we've been successful, but also warns us of any unintended consequences. When innovation doesn't reach the people that need it most, it can actually increase health disparities, which can serve to reduce the health of a population. And Dr. FitzGerald was certainly aware of this. When he created the antitoxin, he made sure that it was sold back to the Provincial Board of Health at cost so that everyone needed it would be able to have access to it. Also, examining innovation in the context of public health means we think about ethical and social issues alongside the innovation, which is really important for our motivation for health for all. And finally, the population health impact of innovation affects our ability to have a sustainable healthcare system. In my research, I've shown that health disparities cost human lives as well as affects the sustainability and costs of our healthcare system. So we need to be thinking about that as we're talking about whether we can afford the system which we all value so much. In my research team, we study how to prevent some of the most common chronic diseases we face today, like type 2 diabetes. But we also study premature mortality. And these early or untimely deaths become an apex indicator of how well prevention and our healthcare innovations are working together. We do this by harnessing the power of data and analytics. And part of my work involves building predictive models. And with these models, we can understand who in the population will benefit from interventions and innovations that we develop. And it's only from this vantage point where we look at the impact, not just the individual benefit of innovation, but the population health impact, where we see where we may not be realizing our full potential. So it's possible that even a truly effective and impactful innovation, if not scaled up appropriately or considered in a population, actually can have no impact. The other aspect of these models is that we work closely with decision makers, and these include people from local public health to regional and provincial planning authorities. And one of the innovative aspects of the model, aside from the unique aspects of the prediction tools and how we've developed and validated them, is that we've developed them on data that are publicly available. So this runs off data that are available to a wide range of users using data at their fingertips that's uniquely available for their community. And in this way, it increases the uptake of the use of these models to inform critical health decisions. When we think about mortality, we've studied all deaths that have happened in Ontario, for example, in the past 20 years. And we see some very interesting patterns. So we've reduced premature mortality significantly over the past 20 years. And this tells us that our advancements in health and our innovations are working. We're having an impact. But when you layer on the different types of data and the different ways to look at premature mortality, we realize that those benefits aren't being experienced by everyone in the population. And we have questions. So why is it that some segments of the population are experiencing steady but significant declines in early deaths, where the others are not experiencing declines and maybe seeing some increases? Why is it that two individuals that are seemingly similar, diagnosed with the same chronic condition, that have such vastly different outcomes, even though they're exposed to the same health system and theoretically the same health innovations? So this type of research allows us to identify our successes, but also perhaps where we need to refocus innovation and think about how innovation can have impact. We're working with health decision makers to tackle these thorny questions and think about innovative cross-sectoral solutions and how we can manage these disparities and reduce them. In my work in developing analytic tools and working with complex data over millions of people over time, it wouldn't have been possible without funding I've received, also from the Connaught Foundation as a new investigator, but also CHR, CFI, the Canada Research Chairs Program, as well as the Ministry of Health and Long-Term Care. And as we celebrate today, I'm confident that University of Toronto will continue the rich tradition of innovation for the next 100 years. But I would propose some thoughts as we think about innovation moving forward from a population health perspective. First, We need to further foster innovation efforts specifically towards prevention. If we want to save lives and reduce healthcare costs, we need to think about prevention in a more innovative way. Despite knowing how burdensome chronic diseases are both to individuals, to populations, to healthcare systems, we still have fairly rudimentary ways to think about prevention and very small scale ways. We haven't scaled up significantly for the most part. And as public health continues to remind us, we need to open our minds at what needles we are aiming to push with prevention. There are broad determinants of health, and without addressing these determinants, we're not going to have the impact that we would like to have with prevention. So with that goal of prevention and health equity, maybe innovation looks a little bit different. Perhaps it's in the way we build our cities, it's in the government policy or legislation, or maybe how we structure social assistance programs. Innovations today that will recognize and address these broader and critical domains of health will represent the biggest promise moving forward. Secondly, we do need to harness the power of data to inform innovation. And we've heard a lot about data in the context of precision medicine, which is important. That is harnessing every bit of biological data we can get our hands onto to improve treatment and outcomes. But we can apply that same thinking to population health, to use data to better inform what innovations will work and in what context, using multiple types of data. The reality is we live in a society where your postal code, or even if you have a postal code, predicts your life expectancy better than your genetic code. So the innovations of the future that harness factors across economic, social, behavioral, and biological domains will have the most impactful changes. And finally, we need to improve our ability to track the impact of our interventions and innovations and clearly demonstrate both the societal and the economic impact. This requires a long-term perspective because sometimes the benefits of prevention may not be imminent. It also requires resources to continually and rigorously evaluate the impact. And this helps us define ourselves by the benefits we provide, not just by the innovations themselves. So we are more than just producers of antitoxins or apps or predictive models. Our innovations help everyone in society live longer and healthier lives. And we could add to that, they also contribute to a more sustainable health system. And the better we get at evaluating and demonstrating this type of impact, the more we will be able to foster further innovation for years to come. I lastly just want to comment about innovation in the context of a university. Dr. FitzGerald went away to Europe in his postgraduate training and came back to specifically foster that eye of innovation that he saw in Europe here at the University of Toronto, a place where research and innovation takes place alongside teaching and education. And as we heard, that's a really magical combination. Innovation that happens at an institution where we're also educating and inspiring the younger generation brings with it creativity, vision, passion, energy, and enthusiasm from our students. And that's a powerful driving force behind discovery. Embedding that innovation in a sea of learners means that it will diversify, we'll get new perspectives, and it'll expand through generations. And Dr. FitzGerald certainly did this. He inspired physicians and scientists to think about innovation in the health context in a totally different way, to literally think of innovations that could save hundreds and thousands and millions of lives. It's actually my favorite part of being a professor. The idea of creating innovation in a space where you're also educating and mentoring. Because you know that you're doing so much more than that particular innovation or that research that you're doing at that particular moment or what you're teaching at that moment. You're actually fostering a hub that will continually generate solutions for society for many years to come. So it has a much more lasting impact. When I look back to the events that we're celebrating today, I note that there's a dynamism and flexibility in the way that our pioneers were able to respond to the challenges facing society at the time. In order for us to do that today, we need stable funding that allows researchers to be creative, yet responsive, and allows us to adapt our skills and efforts to the most pressing concerns of society. I also firmly believe that embedding that innovation in the context of a university means that we're continuing to foster that spirit of discovery, not just in this moment, but for many years to come. Thank you.
think there should be a microphone for each of us here. Okay. Okay, so first of all, I'd like to thank all three speakers. These chairs are really cushy.
I know,
For the great remarks and also for everyone sticking to their time so well. So really appreciate that. So we have time for discussion, and in a few minutes we'll invite people in the audience who'd like to ask questions to come up to the microphone in the middle. But I'll start with a couple of questions of my own. Each of you touched in a different way around disrupting the way in which things, whether it's disrupting how drug discovery is done, discovering how we evaluate new technologies. I remember I had a Palm Pilot. And I think I even remember doing a study on a Palm Pilot. The results will probably be coming out now. And how we deliver data and information to decision makers. So should we also be thinking about disrupting the way in which we do research or support research? As the VP research, should you want to get rid of my job? No.
I think I could make a comment in terms of disrupting the way that we do research. I think we're always trying to look at the ways that we can sort of facilitate innovation and discovery. And one example that's sort of poignant right now is the Faculty of Medicine was able to invest and move a whole large group of researchers from different departments from the medical sciences building into a brand new sort of research tower at Mars. And the idea was to break down departmental silos. For example, we have on the 16th floor an infectious disease research community, which involves researchers from biochemistry, from molecular genetics, and we're situated right below Public Health Ontario, which then positions us very nicely to sort of be ready to deal with these latest outbreaks, for example. We're also positioned right within reach of Mars Innovation, which facilitates sort of commercialization and knowledge translation. So I think that's a beautiful example of a way in which sort of changing the space, the organization, and the way in which different researchers are grouped together has enabled discovery. It's been transformative. All the students, instead of being in sort of enclosed spaces without windows, are now in sort of this open community where they can interact with other members from other labs and other departments and other research areas. So I think that's been transformative. And I would also say in terms of thinking about funding, we're in a difficult moment right now where federal funding is tight, to say the least. And so I think everyone has had to be very creative in thinking about how best to fund their research enterprise. And I think that's promoted a lot of fantastic partnerships and thinking about how we can work together both as teams within the university and across the university, and also in terms of building partnerships with other organizations. A lovely example that comes to mind right at the moment, because I'm looking at two individuals here, is we've built a recent partnership with Sanofi Pasteur, so relevant to today. We've got Bruce Seat and Dion Neem here today. And so we've been able to sort of think about how we can strategize and find complementary research areas, and even strategize how we can think about training and training personnel so that they're job ready and really ready to read the market. So I think sort of creativity in both how we organize our research infrastructure, how we organize our researchers, how we promote collaboration, and then how we fund our research programs has been key.
Great, and maybe I'll just add a couple of thoughts as well. I think one is, because I work with technology a lot, is how do we fundamentally think about if we're doing quality improvement or we're actually doing research? And I get the question a lot because we have to go through RAB, right? And the Research Ethics Board seems to have a different path if it's quality improvement or whether it's actually research. And to me, I think it's almost a spectrum and kind of like a continuous spectrum, in that a lot of the quality improvement research, quality improvement is really research, right? And so how do we embed some of our research into programs already, and how do we really get more information out of that? Because I don't think we're doing that well. My other thought around that is, especially around the type of technologies I work with, we can't really have these static types of trials, right, where we kind of freeze the intervention. And so I'm kind of looking towards how do we actually do iterative research, right, and actually bring that information quickly around so that we can actually embed it into our system rather quickly, instead of waiting again years and years before we make a change.
I I take just a little bit of a different perspective. I think one of the changes I think would be important would be our metrics of success in research. So one of the curious things about research funding is the more successful you are on these traditional metrics, the more research funding you get, and it's sort of circular. I know in my work, a lot of my most successful research isn't in the form of a peer-reviewed publication or a grant. Maybe it's helping a community answer a problem or changing a legislation. And we haven't found a way to actually reward that type of work. It's hugely impactful. So that's one of the changes I would like to see.
Thanks. So we have, can you please introduce yourself? And oh, microphone on?
Is that one? Yes, thanks. Thanks very much.
It's good.
So I'm Roland Hussain from the School of Public Health. And for our colleague who talked about a variety of apps, 325,000 apps in health, in medicine. When you look at the issues with the good that social media can do, and you look at the issues, the bad it can do, when you look at the technology, what can you do, what can we do to ensure that the apps do cause good and will not cause harm?
So I think that's a very interesting question, because it's about how do we design them as well as how do we implement them, right? So when we're looking at how we can do good with them, you have to put some safeguards around it. So you mentioned social media, and there's been a lot of talk about putting a safe environment, right, around if you want to go and share your own health experiences. And I think that there are measures such as mediation, for example, where you can make sure that, first of all, that people are not getting attacked in social media, which I think is important when you're looking at sharing very personal information. So, you know, I think that, again, this is kind of a dual thing where you have to make sure that the features that are put in place, you have to put in, for example, obviously they know where the data is being held, for example, so being transparent about that. So again, how you design the intervention and also how you implement them, right? So that they're in a safe environment and that they're safeguards against things such as, you know, people stealing your information or, you know, all the kind of negative things that come along with types of apps that people are thinking about these days.
Senator Mike.
Vivek, thank you. I'm Peter Donnelly. I'm President and Chief Executive of Public Health Ontario. So first of all, thank you for this event. I love this format. I think this is really fun. And great talks. I enjoyed all of them. I want to try and tempt our panelists into speculating a little bit about the next 10 years. I think they've done a tremendous job of summarizing for us the major developments in their fields in the last 10 years. And we've also quite rightly heard quite a bit about the history of, if you like, of innovation in the city and in the university. But I'd quite like to hear what might happen in the next 10 years. So can I challenge our three panelists to, if they were allowed to just pick one thing that would actually happen in their field in the next 10 years, what would that one most important, most impactful thing be?
Who wants to start? Great question, Peter.
Well, maybe, sure, I'll start.
Yeah.
I think that if I had that gene in the bottle, I guess, it would be connected care and networked information. I think that in the next 10 years, if we could get all the data so that it's all integrated and that all the care team can see it, and this includes informal caregivers, the patients, and the healthcare professionals, and getting all the information from home, from their genetic information, from their EMR data. If we could pull this all together, I think we could do amazing things for healthcare. And I'm hopeful that in 10 years, we'll have things such as smart homes, right? Where you stand on a weight scale, you get your weight, integrated technology that will help improve patient, the care of the health of all consumers, really.
Thanks for the easy question, Peter. But I was also going to move to data. I think if we could enrich our data sources so that we're measuring, we don't have such a narrow view of what we're measuring on individuals, and we can broaden those data sources and make them linkable and more accessible. I think it's less about getting new types of data that we don't have, but more taking data that already exist and connecting them better. That would be my number one wish. So to echo that, but if I can add a second part, I would also like to see data and analytics be better integrated into decision making. And so I spoke about this before, that I think we need to think about how we're translating data for decision making in a more effective and easy way so it's actually used. Because it's quite scary actually watching policy making being done in the absence of science and also in the absence of data. So I think it's very important for society that we stay on that point.
And I will move away from data and say we need more drugs, and that's what we're going to do. So I think that there's a real dearth in the capacity to fund getting programs from sort of the preclinical stage, which is really where you get to in an academic program, and getting that out to a drug that can actually be deployed. So there's a huge dearth because sort of investment from venture capital and others, it's limited until you've already got it working in an animal model, as just an example. So I think that there needs to be sort of a transformation in how we fund many of these research programs, and we already see that happening through various mechanisms in the US, for example. And I think we need many different new antimicrobials, for example, because we can't have small sets of arsenals of antimicrobials because resistance will evolve, evolution happens, it will win. And so we need many options because often there's sort of trade-offs where resistance to one lets you be more vulnerable to another. So we need sort of a big compendium, a larger arsenal of antimicrobials, and we also need better vaccines. And I think there's a lot of really exciting research which suggests we can do the kind of transformative work that has been done in the past with vaccines to be able to render certain kinds of infectious disease no longer a major threat to human health. So drugs and vaccines would be my bet.
We have time for one more over at this microphone.
My name is Dr. Humphreys. I graduated in public health here from the University of Toronto a few years ago. I would like to go back to the day of Gooderham and FitzGerald with regards to the crisis that they were facing at that time. Diphtheria, tetanus, pertussis. They worked and got that developed with regards to vaccines. Today, what is the most major crisis that we're facing in public health today? And I have not heard any of you people mention about it. The opioid crisis. What are we doing here at the University of Toronto Public Health in terms of research with regards to the opioid crisis?
That's a great question that does not fall to me. So.
Yeah.
Sure, I can speak to that.
Someone else.
So actually, we have a number of scholars, both at the Dalla School of Public Health and as well as Public Health Ontario, that have actually been researching this issue for years, actually sounding the alarm bells about the opioid crisis, who it affects, and the detriments that it could have to society for a long time. And from our school's perspective, we have people looking at it from the social justice perspective, from the data perspective, from the pharmacological perspective. So there's actually a lot of interesting research happening. I think it's a very complex issue. It's like almost every other public health complex issue. There's social issues that underlie it. There's clinical considerations, and we have a lot of activity in this area.
So I'll just add in, since I've been involved in as well, that I think again, as Laura's saying, this is something that requires partnerships. We got people from hospitals and from other health organizations here as well. I'll note that at the University of Toronto, it was our researchers that, as Laura's saying, over 5 years ago, that were starting to raise the warning bells. They were doing research on safe injection facilities, along with colleagues in Vancouver, who are really at the forefront of the interventions that we can put in place within psychiatry, and we're going to have our dean speak in a few minutes. Within the Department of Pharmacology, we have many researchers that have been working on this as well. But this is, it is a great relationship to what we were facing as a society 100 years ago, in that it was also complex. I started with diphtheria, it was complex. It was a social issue as well as an infectious disease issue. The opioid crisis is the result of how we've managed pain for many decades, or perhaps mismanaged pain has led to this, and there's not going to be a quick or easy fix to it. So very quick question, and then we'll wrap up the panel.
So I'm Johannes Paulus. I'm a student at York University working for Dr. David. So my question is, what are some of, my question is on mHealth and the buy-in. The buy-in is always a challenge. You know, when you go to communities with this new app, there are obviously challenges in buying into this innovation. So what are some of the challenges that you face, and how have you tried to overcome that buy-in question? And the last question is, insofar as we're carrying out this amazing research, how do we still maintain the traditional knowledge, the traditional systems where we work and where we operate in? Thank you.
So, sorry, were you saying buy-in of apps? So, yeah, so I think that in terms of the consumer health, I don't know if there's a lot of necessary for buy-in, because consumers love to try things, right? So there's a million apps and people will try them. The problem is that they don't adhere to them, right? So I'm sure all of you have downloaded something or bought a Fitbit and then it gets shelved, right? So I think the problem here is actually how sustained use more than the buy-in. On the clinical side, it's a little bit different. If you're talking about buy-in from the clinicians, is that what you mean? So that's really hard. And you have to kind of partner with clinical champions who are kind of forward-thinking, right? And they see a value in terms of using this kind of information. And it's not easy to do, to tell you the truth. And I think it's a slow progression of seeing how these types of apps can actually help them instead of hindering them. So once you are saying, this is going to take you more time and I'm not paying you to take a look at this information, it's not going to work, right? So what you need to do is embed it into their workflow so that it's seamless and it has a value add to them, if that makes sense. So you have to kind of show them off the bat that this is helping them instead of hindering them. And it's helping the patients. I'm not sure if I quite caught your second question there. It was on traditional knowledge. So so do you mean like in terms of the traditional knowledge of evaluation? Is that what you mean?
No, I think traditional knowledge of different cultures.
Oh,
Yeah.
oh, I see, of the culture, of cultures.
Yeah.
Oh, I see. So I think there's ways of doing, again, falling back to kind of participatory research and understanding at the ground level, what are the needs requirements. So when we're developing any of these apps, what we have to do is figure out what are the requirements. And that takes a lot of work, right? And to see what's going to be useful and what can be embedded into their society and culture. So I think you have to kind of peel it back, right? It's not about the apps, it's not about the technology, it's about what is it that you're trying to do fundamentally, right? And so you start from that perspective and see if technology is the way an app is a solution. Because sometimes it's not, right? It may be a phone call, it may be something very different, but you have to find out what the problem is, figure out how it fits into the way that they live and their culture, and see if you can tailor something that fits into their way of life.
Okay, so I think I'm going to wrap it up because we're at time, but I just want to make an observation based on the discussion. What we skipped in the history, and it speaks to traditional knowledge and not ignoring what's happening in broader society. What we skipped in the history was what many would see as a dark period for public health at the university, because after the university sold the Connaught Labs, they also made a decision to close the School of Hygiene. And that decision was made at that time because there was a view that infectious diseases had been beaten. And the future challenges were chronic diseases, and those are going to be dealt with by modern medicine that was being developed, whether it's diabetes, heart disease, and so on. And it's fun to see that our colleague from the Faculty of Medicine today is reminding us of the importance of infectious disease, and our speakers from public health are focused on chronic diseases. And so it goes back and forth. And within all of that, and Dr. Humphrey's reminder is really important, we often forget about, and I'll make it broader, mental health and other conditions that affect society. And so I think an important message would be that we have to remain cognizant of the breadth of the challenges that we face, and not the one that is most urgent now, and certainly not close schools as a result of that. So with that, I'll invite our Dean of Medicine and Professor of Psychiatry, Professor Trevor Young, to make closing remarks.
Thank you, Vivek, and thank you, Steini, for co-hosting this fantastic evening, celebrating our very rich history of innovation at University of Toronto. Definitely, we're glad to have a wonderfully strong School of Public Health as a great partner with us in the Faculty of Medicine, and the many hospital institutes that we have across this wonderful city. As researchers and supporters of research, all of us have a role to play in Dr. FitzGerald's legacy of discovery and advocacy to improve the lives of others. I think we are in very good hands for the future of our field with these terrific panelists here. Please join me in thanking Leah Cohen, Laura Rosella, and Emily Cito. U of T is part of an extremely productive ecosystem of discovery that links our faculties, our hospital-based research institutes, partners in public health, and our supporters in both the broader public and private sectors. And as you know, research is a highly collaborative endeavor, and as a long game, as Vivek called it earlier, across disciplines and around the world. Canadians reap the benefits of the last 100 years of research every day, every successful cancer treatment, every infectious disease beaten back, every premature baby now thriving. All these achievements began with an idea, one that was rigorously tested, refined and retested, proving its value across population over time. This is the work our researchers do every day. It's painstaking, not always glamorous, but it's work that gives Canadians hope for the future and drives a diverse and innovative economy forward. We like to think of Canada as a nation that punches above its weight in terms of research, but as Vivek pointed out, the Naylor report suggests that by various measures, our competitiveness has eroded against many of our international peers. His report, David Naylor's report, is quite clear. Governance cannot shortchange basic science and expect innovation to flourish. So please, if you value fundamental science, as Dr. FitzGerald and our panelists here tonight have demonstrated, find ways to make your views known to leaders in Ottawa and beyond. One easy way will be to grab the postcard, which is on your seat, and you can fill it in, and we'll have a basket, we'll collect them, we'll save you postage, and we'll make sure that they get to Minister Duncan. So please add whatever you like, and you can also write separately if you like. So one final thought as you leave, if you do the math on the phased-in 4-year funding increase of the Naylor report, I was just at the UHN board, and Brad Waters went through it one more time, so it's fresh in my head. It works out to be about 0.4% of the Government of Canada's annual budget. That works out to be about $9 per Canadian per day. So think about that as a movie ticket on, I think, Tuesday night, a cheap night, or a really bespoke coffee drink at one of these new cold brew places. It's really not a huge amount of money per Canadian. This would signal a new chapter for Canadian research on a global stage, as we've had in our history of the Connaught Labs and many other things. It's an opportunity within reach of each of us. So everybody, please keep your efforts to support the report going, and do join us for a reception just outside the room here, and for some further conversation. Thank you again for my co-hosts, to our wonderful panelists, and to each of you for coming tonight.